This conference will now be recorded.
Okay, so recipe for success. Study while others are sleeping, work while others are laughing, and prepare while others are playing, and dream while others are wishing. Nothing is impossible, dears. And MRCOG, it can be a very smooth journey if you are consistent with your preparations and you have the strong determination. So starting today, I'm covering the guideline that is GTG number 69, which is management of nausea and vomiting in pregnancy and hyperemesis gravidarum. This was put forward in 2016. So let's go through the guideline. The guideline says that nausea and vomiting, NVP, affects 80% of the pregnant women, and it is one of the most common indications for hospital admissions amongst the pregnant women. Hyperemesis gravidarum is a severe form of nausea and vomiting in pregnancy, and it affects 0.3 to 3.6% of the pregnant women. The recurrence rates, if we talk about the recurrence rate, they vary from 15% to 81%. So there is a varied, depending upon this, whether the patient is self-reporting or there are some studies. So there is varying degree of recurrence, but definitely if there is nausea and vomiting and hyperemesis in one pregnancy, then in the consecutive pregnancies, the chances of having the similar condition, they are higher. Nausea and vomiting in pregnancy and hyperemesis, they typically start between 4th and 7th week of gestation. It peaks at 9 weeks and it gets resolved by 20 weeks in 90% of the cases. So remember, when does it peak? It peaks at 9 weeks, okay? And it starts at 4 to 7 weeks. How is it diagnosed? So this triad is very important. This triad is like, I always remembered it by the mnemonic DEW. So if there is dehydration, there is electrolyte imbalance, and there is more than 5% of pre-pregnancy weight loss, then we diagnose it as hyperemesis. So hyperemesis can be diagnosed when there is protracted nausea and vomiting with a triad, of DEW, that is dehydration, electrolyte imbalance, and the weight loss, and the weight loss is more than 5% pre-pregnancy weight loss. This is an important single best answer. The severity of nausea and vomiting in pregnancy, it can be classified, or it can be, there is an index which is used to quantify the nausea and vomiting, and the scoring system which is used is known as the puke score. Okay, the scoring system is very important. So puke score, it stands for pregnancy unique quantification of emesis. So this is the scoring system which we are using, and it is an objective and validated index of nausea and vomiting. So the puke score, the total score of puke is 24. So the patient is said to have mild condition if the score is 6 or less than 6, moderate condition if the score is 7 to 12, and severe condition if it is between 13 to 15. The questions which are asked from the mother are, there are 3 questions which are asked. In the past 24 hours, how long have you feel nauseated or sick to your stomach? In the last 24 hours, have you vomited or thrown up? In the last 24 hours, how many times you had retching or dry heaves without bringing anything up? So depending upon what the answer patient gives to you, so the answer can be scored as 1, 2, 3, 4, 5, or is like if the episodes of vomiting are 7 or more, it is 5, 4, 3, 2, 1. So then we add on all these scores. You need not remember these score, they are not important. However, you have to remember which is the scoring system used, the name, and how do you quantify it as mild, moderate, and severe. So anything which is 6 or less than 6 is mild, 7 to 12 is moderate, and 13 to 15 is severe. What initial clinical assessment and baseline investigation should be done before deciding on the treatment? So the history and examinations and investigations which need to be done to monitor severity and other causes. In history, we have to ask any previous history of nausea and vomiting. We have to quantify the severity of nausea and vomiting using puke score. We have to ask about nausea, vomiting, hypersalivation, spitting, loss of weight, inability to tolerate food and fluids, and how the condition is affecting her quality of life. And other things which have to be asked is we have to exclude the other causes. To exclude the other causes of nausea and vomiting, we have to ask about abdominal pain, because gastritis can also present with like that. Cholecystitis can also present with nausea and vomiting, even hepatitis, urinary symptoms to just rule out UTI, any infections, any drug history, any H. pylori infestation. So all this has to be asked. In examination, all the vitals have to be checked: heart, blood pressure, pulse temperature, respiratory rate, oxygen saturation. Upper abdominal examination, what is the weight, any signs of dehydration, signs of muscle wasting. Other examination as guided by the history. The investigations which need to be done in a patient with hyperemesis is we have to firstly do a urine dipstick test, because we have to quantify the ketones. And ketone urea is classified when there is 1+ ketones or more present in the urine. Okay, so this points towards the state of dehydration or starvation. Then we have to do a midstream urine analysis. We have to do kidney function test. That is, we have to look for any electrolyte imbalance, hypokalemia, hyperkalemia, hyponatremia, whether there is any dehydration, renal disease. So urea and electrolytes are to be done. Then full blood count is to be done to look for any anemia, infection, hematocrit, blood glucose level to exclude diabetic ketoacidosis, ultrasound scan to confirm viable intrauterine pregnancy and exclude multiple pregnancy and trophoblastic disease. And if it is a refractory case, if the patient is not responding to any treatment, then we have to check further how are the thyroid function tests, how are the liver function tests. So we have to rule out hypothyroidism, hyperthyroidism, any liver pathology like hepatitis, gallstones, malnutrition. We have to look for calcium levels, phosphate levels, amylase, and ABG to exclude any metabolic disturbances. Nausea and vomiting and hyperemesis, they are mainly associated with hyponatremia, hypokalemia, low serum urea level, and raised hematocrit level, and ketonuria with a metabolic hypochloremic alkalosis. So this is the effect which occurs because of nausea, and it is an important single best answer. So it is metabolic hypochloremic alkalosis, which occurs because of hyperemesis gravidarum. If it is a very severe case, then metabolic acidemia can develop. So it is mainly metabolic hypochloremic alkalosis. But if the condition gets very severe, then metabolic acidemia can develop. So we can see over here that the sodium levels, potassium levels, urea, and chloride levels, they are decreasing, whereas the hematocrit is increasing. So there is alkalosis, there is metabolic hypochloremic alkalosis, and if the condition is not treated and if it becomes a severe one, then acidosis can result. So this slide is very, very important. Talking about, there can be with hyperemesis gravidarum, there can be associated abnormalities in the thyroid function test as well as the liver function test. So thyroid function test abnormalities is found in 66.67% of the cases. That is 2/3 of the cases with hyperemesis, they may have thyroid abnormalities. Why does it occur? It occurs because of the structural similarity between the thyroid stimulating hormone and the HCG. Okay, so with biochemical thyrotoxicosis. So this HCG, it stimulates the thyroid gland because it has the structural similarity with the TSH, and this leads to raised level of free thyroxine level with or without a suppressed TSH level. So TSH level may or may not be suppressed, but there is raised free thyroxine levels. These patients rarely have thyroid antibodies because here the culprit is HCG, which has the structural similarity with the TSH, and they are euthyroid clinically. So remember this percentage, 2/3 of the patients with hyperemesis, they have thyroid. Thyroid is located at a higher level than the liver. So the thyroid abnormality associated with the hyperemesis is present in 66.67%, whereas abnormal liver function tests, they are present in 40% of the cases. So the biochemical thyrotoxicosis resolves as the hyperemesis gravidarum, it improves, and treatment with anti-thyroid drug is inappropriate. So as I have told you, the liver function tests, they are raised in 40% of the cases. And this is the abnormality in the liver function test is the rise in the transaminases level and slightly higher bilirubin level in some cases. So remember these percentages, they are very, very important. Remember that the thyroid in our body is located at a higher level. So the abnormality with the thyroid is higher with hyperemesis. It is present in 66.6% of the cases with respect to the liver pathology, which is present in 40% of the cases. What are the differential diagnoses of hyperemesis? So other pathological causes should be excluded by clinical history, focus examination, and investigation. So the other conditions which needs to be excluded, they are the peptic ulcers, cholecystitis. That's why we are asking about any pain in the abdomen. Then gastroenteritis, hepatitis, all the inflammations of the organs, of the abdominal organs. Then genitourinary conditions like urinary tract infections or pyelonephritis, metabolic condition, neurological conditions, and drug-induced nausea and vomiting. If there is severe abdominal or epigastric pain, then we have to think of alternative diagnosis because severe abdominal pain is never associated with hyperemesis gravidarum. In that case, we have to do serum amylase level, esophageal gastroduodenoscopy, and H. pylori antibodies. So these tests can be done to rule out any gastritis or any peptic ulcers, any pancreatitis, or any gastritis. So these tests have to be done. So this chart is very, very important. How do we manage a case of hyperemesis? So the initial assessment should be done for the patient, and we should exclude the other causes. We should record the puke score of the patient and assess for clinical complications. So what are the clinical complications which are present? So there can be dehydration, there can be electrolyte imbalance, or there can be weight loss. We will offer advice and support. So depending upon the puke score, what is the puke score? If the puke score is 3 to 12 and there is no complication, then antiemetics can be given in the community. And we can just go for lifestyle measures and the dietary changes. If the puke score is 13 or above, but there are no complications and there is no the patient is not refractory to antiemetics, in that case, ambulatory daycare management can be done until there is no ketonuria. Provided there are no ketones in the urine and the puke score, if it is 13 or more, but there shouldn't be any complications and the patient shouldn't be refractory to antiemetics and there shouldn't be any ketonuria. In that case, we can give her ambulatory daycare management. So how we are giving ambulatory daycare management? We can remember it as FAT, where F stands for we have to give fast intravenous hydration with normal saline and potassium if there is no contraindication to use that. A stands for we have to give antiemetics, and T stands for we have to give thiamine also. Because if we don't cover thiamine, we don't give thiamine, that is vitamin B1, then in that case, there can be oneikis enchophilopathy. If we are giving dextrose, we are not correcting the sodium levels, there is hyponatremia, and we are not correcting the thiamine levels, then oneikis enchophilopathy can get precipitated because of thiamine deficiency. So it is very important that we are giving supplements with thiamine also. If there is any complications which is associated with hyperemesis gravidarum, no doubt whatever is the puke score, so any puke score, but if complication is there, that is there is dehydration, there is ketonuria, or there is any electrolyte imbalance, so in that case we have to offer her inpatient management. Inpatient management is a must in that case. Okay, so inpatient management is done in a similar manner as the ambulatory daycare management. That is, we have to give fast intravenous hydration with normal saline and potassium. We have to give antiemetics, thiamine, and then we have to give, along with it, we have to give CMT. That is, we have to consider giving steroids. Multidisciplinary team approach should be given to the patient, and we should consider for thromboprophylaxis also. We have to do a DVT risk assessment for her. So this chart is very, very important. In the scenario, they can give any puke score. They can ask you what is the next line of management. So remember, puke score between 3 to 12 can be given antiemetics in community provided there is no complication. Puke score 13 and above, if there is no complication, ambulatory daycare management can be done. However, if there is any complication, then we have to consider inpatient management, and whenever we are admitting a patient, an antenatal patient, we have to consider giving thromboprophylaxis as well. Talking about the antiemetics now, so we have first line, second line, and third line antiemetics. So let's go through them one by one. First line antiemetics can be remembered as C square, P square. So here C stands for cyclizine, and it stands for chlorpromazine, and P stands for prochlorperazine and promethazine. So cyclizine dosage is 50 milligram through all the routes, that is per oral, intramuscular, or intravaginal or intravenous. So any route we are giving, the dosage is the same, that is 50 milligram, and it is given at 8-hourly interval. Then chlorpromazine, it is 10 to 25 milligram, which is given at 4 to 6 hourly interval per oral, intravenous, or intramuscular, or 50 to 100 milligram, 6 to 8 hourly per rectal. You need not remember all the dosage, but you should be remembering what are the first line medications, what are the second line medications, and what is the third line medication. So in the first line, we have cyclizine, chlorpromazine, promethazine, and prochlorperazine. So remember it as C square, P square. Second line medications, we have MOD, that is metoclopramide, ondansetron, and domperidone. So metoclopramide is 5 to 10 milligram 8-hourly through all the routes per oral, intravenous, or intramuscular. However, the maximum duration for which we can give this metoclopramide, that is the perinom injection, it is maximum 5 days, because it can, if we exceed this duration, then extrapyramidal side effects can occur. And whenever we are giving intravenous dosage, it is very important that we give very slowly over at least 3 minutes. Ondansetron is 4 to 8 milligram 6 to 8 hourly per oral, or 8 milligram over 15 minutes 12 hourly intravenously. Domperidone is 10 milligram 8 hourly per oral, or 30 to 80 milligram 8 hourly per rectally. Again, dosages, they are not that important, but the names of the medication, they are important. Third line, we have steroids. So normally we are giving hydrocortisone here. So it is 100 milligram twice daily intravenously. And once there is clinical improvement, then we convert it to prednisolone. So what is the dosage of prednisolone? We will just make half of hydrocortisone. So we were giving 100 milligram of hydrocortisone. So prednisolone will be 50 milligram. And we were giving hydrocortisone twice daily. So prednisolone will be given daily, but it will be through per oral route. So the dosage will be gradually tapered of these steroids until the lowest maintenance dose that controls the symptoms is reached. Combination of different drugs should be used in women who do not respond to single antiemetics. For women with persistent or severe hyperemesis, the parental or the rectal route should be considered. Drug-induced extrapyramidal symptoms or oculogyric crisis can occur with phenothiazines and with metoclopramide. So whenever there are any such symptoms like tardive dyskinesia or oculogyric crisis, this indicates prompt cessation of these medications. So whenever we are giving phenothiazines or metoclopramide and we see that the patient is having any extrapyramidal side effects, then in that case, we have to promptly stop these medication. So remember, this is a very, very important slide. What are the first line medications, second line, and the third line medications? Pyridoxine is not normally recommended for nausea and vomiting and hyperemesis according to GTG. Even diazepam is not recommended. Corticosteroids should be reserved for cases where standard therapies have failed. In most cases, prednisolone needs to be continued until the gestational age at which hyperemesis would have typically resolved, and in some extreme cases, it occurs at the time of delivery. Talking about the complementary therapies, so ginger, it has grade A recommendation. Ginger may be used by the women with mild to moderate nausea and vomiting in pregnancy who do not wish to take antiemetics. Okay, so ginger has positive effects in NVP. Women may be reassured that acustimulations, they are safe in pregnancy. Acupuncture may improve nausea and vomiting in pregnancy. And the grade of recommendation here is grade B. However, hypnotic therapies should not be recommended. Hypnotic therapies, there is no role of hypnotic therapies to manage nausea and vomiting. Remember this. What is the best rehydration regimen for ambulatory daycare and inpatient management? So the best rehydration regimen is normal saline. This is a very, very important question. That is 0.9% normal saline with potassium chloride in each bag, with administration guided by daily monitoring of electrolytes. So this is the rehydration fluid of choice. Dextrose infusions are not appropriate unless serum sodium levels are normal and thiamine has been administered, as this can precipitate oneikis enchophilopathy. So dextrose should never ever be given alone because this can precipitate this medical emergency, that is oneikis enchophilopathy. So unless and until sodium levels are normal and thiamine has been given, dextrose should never be given alone. And what is the thiamine dose we have to give? So we have to give 100 milligram daily injections of thiamine through the parental route if the dextrose is being given as a rehydration fluid. So remember the dosage, 100 milligram of thiamine has to be given daily. What are the complications or adverse effects which can occur from nausea and vomiting? So there can be urea and serum electrolyte levels imbalance can be there. So they should be checked daily. Histamine receptor antagonist and proton pump inhibitor. So there can be GERD. There can, because of excessive nausea and vomiting, can lead to gastroesophageal reflux disease, esophagitis, and gastritis. In that case, we have to give histamine antagonist and the proton pump inhibitors. Even the thiamine supplementation should be given either through oral or intravenous route, and it should be given to all the women admitted with prolonged vomiting, especially before administration of dextrose, as giving dextrose alone can precipitate oneikis. Then women who are admitted with hyperemesis gravidarum should be offered thromboprophylaxis with LMWH, because these women, they are already dehydrated, they are antenatal, they are at a high risk of having thrombus formation. So thromboprophylaxis should be given to them. However, thromboprophylaxis can be discontinued when the patient is being discharged. Women with nausea and vomiting and hyperemesis should consider avoiding iron-containing preparations if these exacerbate the symptoms. Oneikis enchophilopathy occurs because of vitamin B1 deficiency, where there is blurring of vision, unsteadiness, a confusion state, there can be memory problems, there can be drowsiness. On examination, there is usually nystagmus, there is ophthalmoplegia, hyporeflexia or areflexia, gait or finger nose ataxia can be there. And Wernicke's enchophilopathy psychosis can be, the symptoms can be remembered as caught rag. So encephalopathy is characterized by a state of confusion, ophthalmoplegia, ataxia. This occurs because of thiamine deficiency. And Korsakoff psychosis, there is retrograde amnesia, antegrade amnesia, confabulation, and Korsakoff psychosis. Association between Wernicke's encephalopathy and administration of intravenous dextrose and parental nutrition is there. Complete remission occurs in only 29% of the cases, and permanent residual impairment, it is very common. The overall pregnancy loss rate, which is associated with Wernicke's, including IUDs and termination, is 48%. Therefore, thiamine supplementation is recommended for all the women with protracted vomiting. Talking about the enteral or the parental treatment. So when all other medical therapies have failed, then enteral or parental treatment should be considered under multidisciplinary approach. What is the MDT team which is involved in hyperemesis? So it is the midwives, the nurses, dietitian, pharmacist, endocrinologist, nutritionalist, gastroenterologist, mental health, because we have to involve the counselors and the psychiatrists also. So the enteral nutrition can be given through nasogastric tube, nasoduodenal, nasojejunal tubes, and percutaneous endoscopic gastrostomy or jejunostomy can be done. Parental feeding with peripherally inserted central catheter is often better tolerated than the enteral feeding. However, it carries risk of infection and vascular perforation. So even parental feeding with peripherally insert central catheter, you can do feeding through that also. Termination of pregnancy in hyperemesis. So all the therapeutic measures should have been tried before offering a termination of a wanted pregnancy. 10% of the pregnancies which are complicated by hyperemesis may end up in termination. This can be a single best answer. So 10% of the pregnancies which are complicated by hyperemesis, they may end up in termination. And whenever you are considering termination, it is very important that before that a multidisciplinary team meeting has been conducted, and a psychiatric opinion should be sought, and the discussion should have taken place before termination. So this again can be an important question in the exam. So what are the effects on the baby with nausea and vomiting and hyperemesis? So women with severe nausea and vomiting and hyperemesis, who have continued symptoms into their late second and third trimester also, they should be offered serial growth scans for the growth of the baby. Excessive vomiting in the pregnancy. What do you mean by excessive vomiting? Any vomiting which is lasting for more than 5 months was significantly associated with underweight babies. So the odds ratio was 4.48. So you can see how much is the association with severe vomiting and SGA babies. Those requiring repeated admissions, those females who required repeated admissions because of hyperemesis, they had 18% incident of SGA babies and significantly lower birth weights than the babies of women with hyperemesis gravidarum and single libration. So repeated admissions also has negative impact on the growth of the baby. Recurrence in pregnancy, this I've already told you. So women with previous hyperemesis should be advised that there is risk of recurrence in future pregnancy to the tune of 15 to 81%. So it is very important that early usage of lifestyle measures, dietary modification is done, and antiemetics are given that were found to be useful in the index pregnancy. It is advisable to reduce it, as this can reduce the risk of nausea and vomiting and hyperemesis in the current pregnancy. Okay, so we are over with the guideline. Any doubts? Just a quick review of the questions. I want everyone to answer. So which abnormality of the acid-base balance is most commonly seen in women with nausea and vomiting in pregnancy? You can just type the answers, dears. Which abnormality of the acid base? Yeah, it is metabolic alkalosis. Very correct. Second question, patient with hyperemesis in early pregnancy and her TFT and she has gets her TFT and she has high T4 levels and undetectable TSH. What is the next step you have to do in her case? So this patient has hyperemesis and she is in early pregnancy, gets her TFT done where the T4 is more, but the TS and the TSH is undetectable. So mainly it is occurring because of the HCG, which is stimulating, which has structural similarity with that of the thyroid stimulating hormone. So in that case, as we went through this slide, this was the slide I was talking about. So I have mentioned it clearly in this that anti-thyroid drugs, they are inappropriate. The biochemical thyrotoxicosis resolves as hyperemesis improves, and treatment with anti-thyroid drugs is inappropriate. So you don't have to do anything in this patient. Okay. So the answer here is F. Clear with everyone? Okay. So the next question. Question number 3, the midwife calls you to review the blood results of a woman with hyperemesis. They show an abnormally low TSH and mildly elevated thyroxine. The most likely explanation for this is, yeah, it is the similarity in the molecular structure between HCG and TSH. Very good. Next one, what proportion of the females with hyperemesis have abnormal TFT and LFT respectively? Yes, again it is 2/3 of the females with hyperemesis, they have abnormal TFT and 40% of the females, they have abnormal TFT. So 2/3 means 66.67% they have abnormal TFT and 40% have abnormal LFT. Right. Next question, which is the most appropriate solution for intravenous rehydration? Yeah, it's normal saline with potassium chloride, right? This is an EMQ. So this is the first question. Answer this one first. Yeah, so whenever there is toxicity with metoclopramide, so the antidote of choice here is intravenous procyclidate. Remember, dears. Okay, so the answer for 1 is D, intravenous procyclidate. What about 2? Women with mild to moderate nausea and vomiting does not want to have any drugs. What do you have to give her in that case? Yes, so this has grade A recommendation. So it is the ginger which we are giving to in mild to moderate if the female doesn't want to have any medications. What about the 3? This mode of treatment has no role in hyperemesis. Which among these has no role? Cyclizine, ginger, hypnosis, dextrose, normal saline, acupressure. Yeah, it is the hypnosis which has no role. Excellent. Oneikis in nausea and vomiting in pregnancy occurs due to the deficiency of? Great. Okay. So these are the answers. So thank you, everyone. I hope you like the session, and we are already going through our long course. In case any one of you wants to join, you can join. And thank you all for joining. I hope you like the session, and we'll be keep coming with the free sessions in the coming days also. Take care. Keep studying. Good night, everyone. Good night. Thank you, dear. Thank you, Manikaran. Thank you. Thank you, Mona. Thank you so much. Thank you. You will be provided with the recordings also. Thank you, Archana. Thank you, dear.